Hi, nursing students. This will be a quick overview on cardiac dysrhythmias, the most common ones that you are most likely to be tested on, and the most common ones that you will see in actual practice. Professor C here for those of you that are unfamiliar. Let's get to it. So just as a brief reminder, I wanted to go over symptoms of decreased cardiac output because it doesn't matter what the dysrhythmia is, if all of them are, they can result in these types of symptoms because the heart is not beating the way that it should. So essentially, I'm not getting enough oxygenated blood to my essential organs. Therefore, these are the symptoms that you're more likely to see. Remember, the heart's a muscle. So if my muscle is not working the way that it's going to, I'm not pumping blood out, I'm going to be hypotensive. I'm going to feel dizzy because I don't have enough oxygenated blood. I'm going to feel lightheaded. These symptoms should make sense. If it's a dysrhythmia, then I could actually feel like I'm having a palpitation, like my heart is beating out of my chest. They could be sweating. That's diaphoresis. So again, it doesn't matter what the dysrhythmia is, this is what we could be seeing. So in order to identify a dysrhythmia, you really need to be able to identify normal sinus rhythm and what that looks like. This is what we would hope to see, right? So again, you can see different measurements here. You could see the P wave, that is right here. You can see your QRS complex right here, and you're going to see a T wave. Now, a lot of you are familiar with that term T wave because maybe you're hear about things like hyperkalemia, you hear that spike T wave, right? This is kind of what we're looking at is right there. So I'm trying to get my pen here. So again, anything around here, you're thinking about, uh-oh, hyperkalemia, uh-oh, heart attack. You're always worried about that T wave. So how do you determine the heart rate? That is the first step when you're really looking at this. So I want you to be thinking about this is always going to be a 6-second strip. So you always have to count your QRS intervals, this peak right here, that's the R. So 1, 2, 3, 4, 5, 6, 7, 8. So if this is, I could do 8 times 10 equals 80. My heart rate would be 80 beats per minute. Remember that your normal sinus rhythm, what's the heart rate for that? 60 to 100. So if your heart rate falls between that, you know you are in the realm of normal sinus rhythm. So we will always give you the 6-second strip. So you're always able to multiply all of these complexes by 10 to determine your heart rate. I want you to then, you're always looking to make sure that you have a normal looking P wave before every single QRS complex. So I'm looking P wave, P wave, P wave. Okay, again, again. They're upright. Okay, it's the first waveform that you're normally going to see is that P wave. And that again represents atrial depolarization. It should always be upright with a rounded top to it. So it should always be topped like that. The P wave, we do measure these intervals. So when you're on your computers, you'll typically take your mouse and you're going to measure starting right before it right to the start of that QRX complex. That is this interval right here. So again, the P wave itself should really only be between 0.10 seconds in length. And then you're going to see the QRS after that. That's the next thing that you're going to look at. These normal QRS complexes are usually pointy and skinny, and they should look about the same throughout the entire rhythm here. It should be, you're going to measure this QRS right here, that complex. You're going to measure that from the start to the end there. It should be short, less than 0.10 seconds. When we get into heart blocks, that's really what you're measuring to determine if your client is in a heart block or not. The next one you are going to see after you see that QRS um, is going to be the T wave. Again, we kind of talked about that. And that is going to represent ventricular repolarization. It should always be round and upright. Um, so again, it's not necessarily used for rhythm interpretation, but it can be helpful in monitoring for hypo or hyperkalemia, if they're having a STEMI, which is a heart attack, or other cardiac disorders. So we do really look at that. So you should be seeing, again, all of these in your rhythm strip. Everything should be equal. If I were to measure this R to R from right here to there, I measure that, that should map out the same throughout the entire strip. All of my R to Rs, this is how I determine the rhythm is regular, excuse me, is from those R to Rs. So I used to have to take an index card and I would mark one and one, and then I would map it out through my whole strip. If you're on an exam, you're more than welcome to do something like that to determine if the rhythm is regular or not. Because if it's normal sinus rhythm, this should be regular. It should map out. And I made a little rhyme for you. So normal sinus rhythm is the norm. It's steady and true. A regular beat with a rhythm to pursue. The heart beats at a steady pace, 60 to 100 beats per minute. It's the perfect space. P waves, QRS, and T in line. This rhythm's a sign that everything is fine. Again, calculating your heart rate, 6-second strips. Take the number of QRS complexes within 6 seconds and multiply it by 10, and you will get your heart rate. So again, 1, 2, 3, 4, 5, 6, 60 beats per minute. Does that fall within normal sinus rhythm? It sure does. So that's not sinus bradycardia. That's not sinus tachycardia. That would be normal sinus rhythm. But when we get into the other problems here, these sinus rhythms like sinus tachycardia or sinus bradycardia, everything is normal in these rhythms except for the heart rate. That's what makes this kind of simple. So again, this is a sinus dysrhythmia. And if I see something like sinus bradycardia, we might call it Brady, we might call it sinus Brady, is that everything is normal, just like in normal sinus rhythm, except the heart rate is less than 60 beats per minute. So I do have this kind of magnified in the presentation, but this would technically be like if I was giving you a 6-second strip, you'd again have to calculate the heart rate. So 1, 2, 3. You would technically, if this was a full 6-second strip, you would be multiplying that by 10. The heart rate could be 59. That technically would be sinus bradycardia. But I still see a P wave here before every QRS complex. So P, QRS, there's my T wave, nice and upright. It's not too peaked, and they all look the same. And again, my R to R would map out. That's all the same. So what do we think about when we think about dysrhythmias? You have to think, are they symptomatic or not? Because if they're not having symptoms, you probably are not going to treat it for any dysrhythmia. Okay? Because this is not necessarily a lethal dysrhythmia. If you're an athlete, if you're a runner, you might normally have a low heart rate. That doesn't necessarily mean that we need to treat it. But if they're having symptoms, so any of those symptoms that we discussed in the beginning of the presentation, try and recall some of those. Symptoms of decreased cardiac output. If they're dizzy, they're short of breath, they're diaphoretic, they're hypotensive, okay, then we might have to treat them. So what we use for sinus bradycardia is atropine. And the goal of this is going to be is to increase the heart rate. So if we want to increase the heart rate, then you're going to give atropine. Usually we give 1 milligram IV push, okay, and we might have to repeat it. When we give something like atropine, you're assessing the client therapeutically. We know it works if their heart rate increases and those symptoms that they were complaining about have gone away because we effectively treated it. But say you give atropine and it does not help and they're still having symptoms, that is where they may need to be transcutaneously paced. So if you're transcutaneously pacing somebody, then we have the crash cart and you have the defibrillator. You put the pacing, you put the like the defibrillator pads on, okay, on the front and the back, wherever the picture shows you on the AED machine, and the provider will turn it on to pacing. They will pace the patient. What your job is as a nurse is to make sure that the client is comfortable, because if they're awake and they're getting paced, it is very uncomfortable. They could develop burns from that because it's giving it electricity. So it is very uncomfortable. We only transcutaneously pace for a little while. What I mean by that is it's external, right? They don't have a permanent pacer in yet, but they will go down and get one if they need it. So here's my rhyme for you there. Sinus brady is slow, less than 60 per minute. A heart that beats with rhythm, but it's in a limit. P waves are present, the rhythm's regular too, just slower than normal, but still getting through. If it's too slow, the heart may not flow, causing symptoms like dizziness to show. The opposite end is sinus tachycardia, which again is a regular rhythm with the same characteristics as normal sinus rhythm, except now the heart rate is greater than 100. So let us see. 1, 2, 3, 4, 5, 6, 7, 8, 9. This would technically be 90 if this was the full strip, but we are missing a couple of the QRS complexes just because, again, I have this hyper magnified. But if any of the heart rates are over 100, even if it's 101, that would be sinus tachycardia. But still here, I see a nice P wave. This QRS is less than 0.10 seconds. My PR interval is less than 0.20 seconds. There's no heart block going on. And my R to R are normal. This would match out every single beat. And I have a nice upright T wave. And see here, as it gets faster and faster, it can be more difficult to differentiate between a P and a T wave, but here I can really still see the difference. There is obviously a T wave, obviously a P wave. Think about someone having a fever, they're uncomfortable, they're in pain, right? Those could all be causes of sinus tachycardia. So if it was really that simple, like, hey, I'm in pain, you gave me something for it, now my heart rate goes back into sinus rhythm. That's obviously the goal. If I'm anemic, maybe you're going to treat me with iron, you're going to give me blood. That will treat the sinus tachycardia. If I'm having a heart attack, you need to treat the heart attack. That will alleviate the sinus tachycardia. So for the most thing with this, the treatment is based on the cause. So again, that's what I'm thinking. I'm hypovolemic. I give them fluids, an isotonic fluid that treats that dehydration, and now their heart rate is normal. So it really think that simple, but we might want to give them something like a beta blocker or a calcium channel blocker to control the heart rate because again, the heart is a muscle. So I don't want it to get super tired, right? So that would be a bad thing. So a beta blocker, your LOLs, I could do atenolol, metoprolol, carvedilol, and that can be used to treat sinus tachycardia. But again, you want to use cautiously in patients with asthma or heart failure for the beta blockers. And when it comes to calcium channel blockers like cardizem, which is known as diltiazem, we could also use that as well. And again, we have to use that cautiously in heart failure. Vagal maneuvers, bear down, blow through a straw. If they're confused and not able to follow commands, then I could maybe throw ice in their on their face, in their armpits, on their genitals. That will cause you to bear down, and that could be a vagal response. So there again are examples of your medications for reference. And here is my rhyme for this one. Sinus tach is fast, over 100 beats. The heart races quickly, the rhythm repeats. The P waves are there, but everything's quick. Anxiety or fear, it can make you tick. It's the body's response, sometimes to stress, but if sustained, it could cause more distress. So now we get into some of the other dysrhythmias here, like atrial fibrillation, which is undoubtedly one of the most commonly seen dysrhythmias worldwide. Literally, upward of 6 million Americans are affected with atrial fibrillation. A lot of us just will call this AFib, okay? So this dysrhythmia leads to a lot of other cardiovascular problems, especially strokes. So when you think about a fib, I want you to think about an increased risk of having a stroke. Almost any dysrhythmia that is like you're presenting with symptoms, you're coming to the ER, they probably have atrial fibrillation. So it could be a permanent dysrhythmia for some people. Some people sustain a rhythm like AFib all of the time. Some people, we call it paroxysmal. It'll just come and go, like on its own without any type of treatment. We really call this persistent if it's lasting more than 7 days. And you can see I actually have two different examples here on this strip. So you can see that this looks way faster here than this top one, right? But the big thing with atrial fibrillation is it doesn't have any P waves. Can you really tell on here what any of this is at all? No. You can't see a P wave, you can't see a T wave. The only thing that you can see here is a QRS complex. And doesn't this look very irregular? See, these R to Rs are not matching out. Neither are they here. So again, that is very different. This is closer, this is far away, this is super close, right? A few beats might seem like it's regular, and then this is longer. So AFib is not a regular rhythm here. And again, you can have AFib that's considered control, and what we mean by that is the heart rate is less than 60, or what we'll term it as is uncontrolled atrial fib with rapid ventricular response. That means RVR, and that means that the heart rate is faster. So as you can see, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 11, 12, 13, 14, 15, 16, 17. 17 times 10 is 170. That is the heart rate here, is 170 beats per minute. So you can see that that is going very, very fast here. So when you think about AFib, I want you to think no, this is very chaotic, and you can see these little, I just call it like little pumps that the heart's trying to do. And since it is so chaotic like that, that is why they're at risk for developing things like blood clots. So it's just that, yeah, it's not good. We don't want to see this. So again, if that heart rate's less than 100, we can still say that that's the AV node maintaining that heart rate. If it's greater than that, it's uncontrolled, and we call that AFib with rapid ventricular response. The risk of having anything like AFib is definitely going to increase with age. And there's a lot of different reasons that somebody could have AFib. Again, my elderly clients are going to be more at risk for developing this. High blood pressure, obesity, diabetes, chronic kidney disease, coronary artery disease, all of these are risk factors for this. But regardless, what you're having is a loss of cardiac output. So that is where the symptoms are going to develop, because that it's that loss of that atrial kick. So we're not getting good perfusion there. So again, what you really have to think about is, in general, is this a new onset AFib, like we've never seen this client have this rhythm before, or is it established? And then we also have to, again, look at, do they have symptoms or do they not have symptoms? So what I'm going to be really looking at, again, are they short of breath? Are they really hypotensive? Are they anxious? What are the symptoms? If they're not having any symptoms, then the rule of thumb is, because that risk of blood clots, that we want to anticoagulate these clients because we don't want them to form clots. So initial rate control is necessary. If it's new onset AFib, I want that heart rate to be normal. So I could use digoxin, a beta blocker, calcium channel blockers. And then once that heart rate is managed, then I'm going to think about my antiarrhythmic medications, cardiac ablation, where they scar or destroy that tissue in the heart, or cardioversion. But typically, cardioversion is considered for AFib after we have anticoagulated the client. That is why we want to see, are they having symptoms or not? If they're severely symptomatic and they haven't been anticoagulated, they still may cardiovert the client. But if they're not having symptoms, then I'm definitely going to want to anticoagulate first. So, what are the medications that I'm talking about here? What are my antiarrhythmics? So, really, really quickly, think about, if I'm controlling the heart rate, can I just use something again like my beta blockers or my calcium channel blockers? Absolutely. So again, I could think of starting them on atenolol or metoprolol to get that heart rate controlled. For rhythm control, what are some medications that we might use? Again, we might, I want you to kind of think about it. What medication, what might we use? What are the antiarrhythmics? I hope that you are thinking of amiodarone. That will definitely slow the cardiac action potential, which will slow the heart rate down. And when we give something like amiodarone, we use this IV, and they start the dose higher, and then we drop the dose, and they will go home on oral amiodarone. Anticoagulant wise, we could do heparin, we could do warfarin. Again, whenever you're giving an anticoagulant, you have to monitor them for bleeding, and we monitor, if it's heparin, the PTT. If we are giving something like warfarin, we're going to monitor their INR. I did want to just put on here a little chart that kind of summarizes the difference. Sometimes students get confused on the difference between cardioversion and defibrillation, but essentially, I'm giving them electricity, whether or not it's cardioversion or defibrillation. But the difference is, with cardioversion, is that it's timed. I'm going to deliver that at the peak of the R wave. Do you see that there? Versus defibrillation, where it's uncontrolled. It's any time during the cardiac cycle. So I can't time it because the rhythm is so uncontrolled. There's no way to do that. But you're not the one hitting the button that's timing it. You're just the one there with the client and the cardiologist when they're doing this. So make sure that you are doing the pad placement appropriately, and that you're monitoring the client before and after either of these are happening. And again, here are those medications that we talked about. An AFib is chaotic, no rhythm to find. The atria are quivering, not one beat aligned. The heart's pumping fast, but irregular too. No P waves, just squiggles, that's the clue. AFib can be risky, causing clot formation, so manage it well with careful medication. Now, the big thing that students get confused about is the difference here with AFib and a flutter. This is a less common dysrhythmia that you would see, but again, you can see that there are no P waves here. If anything, we actually call these flutter waves. Okay, and that is one of the key differences in AFib or A flutter is the F waves that we have. And again, this is a dysrhythmia that is outside of that SA node. So there's no P, that is why you don't have P waves. So really think sawtooth, okay? It's more of a sawtooth pattern, but you still can address the heart rate with the QRS complexes here. These can be very, very fast. It could have a rate of up to like 300 plus. It just depends. But you could also have a normal heart rate. We do call this a rapid ventricular response if the heart rate is above 150 here. But what you can really see here is that doesn't this actually look regular? That's one of the best ways to tell the difference between AFib and A flutter, is that this looks pretty regular. Again, AFib is not going to be regular. So again, it's a regular rhythm, and your causes though could be COPD if they had like surgical procedures, a coronary artery bypass graft, pneumectomy, and also they can be seen with things like digoxin toxicity. So they can definitely occur due to more random causes. That's why this is less likely to be seen in something than AFib. So the main goal with atrial flutter is to control the rate. So again, I can use the same types of things that I could with AFib. I could again do my beta blockers, calcium channel blockers, digoxin. But again, if they have heart failure, remember those medications can exacerbate those symptoms, and that would end up resulting in bradycardia. So again, you really always have to monitor the client that what you're doing is actually therapeutic. If the rate is controlled, like the heart rate's less than 100, they might just use a antiarrhythmic to convert the rhythm back to normal sinus rhythm. They could do cardioversion for something like this, but it's not first line treatment unless the client is severely symptomatic because it's not as successful. It just does not work as well. What really we want to do is what caused this, we want to be treating that. So again, if this was caused because they have really high thyroid levels, then they're going to treat the thyroid problem, and that would result in the atrial flutter resolving too. So A flutters rhythm with a sawtooth wave. The atria beats quickly, but not quite so brave. Regular beats, but fast and tight. 250 to 350 beats, they take flight. It's less chaotic than AFib's pace, but still needs attention to keep a steady space. So again, we're not as worried about blood clots and anticoagulation with this. Now, one of the most common things that you will also see is these are under terms called like atrial tachycardia. So again, it's similar to something like sinus tach, but it's not again coming from the sinus node. It's somewhere in the atria. So again, with something like this, I want you to think about these atrial tachycardias, like think about alcohol use, medications, caffeine, stimulants, maybe even like cocaine, methamphetamine. And so we would just need to avoid those, and that could treat the atrial tachycardia just by avoiding that. When you're thinking about supraventricular tachycardia, which is known as SVT, what you're thinking about is a blanket term. When you look at this, are you able to really tell what this is? No, because again, do I see a P wave? Do I see T waves? No, I don't see anything in here. So I don't know what the rhythm is. All I can see is I can calculate the rate. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. I know the heart rate is like 170. So I know that it is going fast. I just don't know what the rhythm is. So we term this supraventricular tachycardia. So this could actually be AFib with RVR. This could be a flutter with RVR or sinus tachycardia even. We don't know what it is. Now, some clients come in with SVT and we again term it paroxysmal. Again, it's very intermittent. It comes on quick and it ends quick without any sort of treatment. So again, think about SVT, narrow QRS complexes. It commonly appears pretty regular, like that does look like a regular rhythm, especially versus something like AFib, and it is very fast. Normally, this is like 150 to 250 beats per minute. And I'm not sure exactly what it is. I just know it's fast. And it's not sinus tach because I can't see a P wave and I can't see a T wave. So we need to figure out what the rhythm is, right? So think about overall treatment, again, for this is based on the symptoms and the underlying rhythm. So the key for this is to figure out the underlying rhythm while slowing down the heart rate. If the patient is symptomatic, then we're going to use certain medications and we could consider cardioversion, but we want to be very careful with that consideration because we don't know the underlying rhythm. So a lot of the times, what we do for something like this, there's a certain medication. Can anybody think about the medication that you might give to temporarily stop the heart so we can better visualize the rhythm? What is that? It's a diagnostic. It is called adenosine. So what that does is it slows down the heart rate temporarily to allow for a better visualization of the rhythm. So basically, we grab the code cart. You put the pads on the client, everything. You tell them they're going to feel weird for a second. And you definitely, when you push it, we do it very rapidly because the half-life is super short, like seconds. So you push 6 milligrams and then you're going to push 20 mLs of normal saline. And the provider is going to look at the screen. It's going to flatline for a second and it's going to reboot. So the goal is that the provider can identify what that rhythm is in that brief interim. So what we would do if they can't tell, you can repeat it. So we give 6 milligrams the first time, and then we could give them 12 milligrams a second time. So again, it can really result in asystole. So you want to have the transcutaneous pacer readily available just in case they don't reboot into whatever it is. So that is the main goal with something like SVT. Figure out what the rhythm is and then treat it. Again, you can think about rate control. It's a fast rhythm. The heart definitely gets tired. So if we can't figure out what is causing it, the adenosine doesn't treat the SVT. So again, it's so temporary. So think about your beta blockers and your calcium channel blockers to slow the heart rate down and rate control it if we need to. Think about if it's medication toxicity or stimulant, we just want to avoid those. That automatically would help treat that problem of SVT. And always assess any of your SVTs again for if it's hypoxia, you're going to give them oxygen. And yeah, that's really, again, if it's symptomatic, they definitely might even use amiodarone to control the heart rate and they might consider cardioversion. Now, what we get into are the bad rhythms here, the ventricular rhythm. So again, those are somewhere within the ventricles. There's not going to be any sort of P wave here again because these are very bad. So any type of like ventricles rhythms, the VTach, VFib, think bad. These are worst case scenarios. Okay. So if we're thinking about VTAC, I want you to think about 3 or more premature ventricular contractions that can happen in a row. Technically speaking, something like VTAC is usually greater than 150 beats per minute, and this again can be a life-threatening dysrhythmia. Because do you think that you're getting good cardiac output with something like this? No, okay? You don't know what the heck this is, except for the QRS looks pretty wide on this one, right? And does this look good? No. You can see that these all look the same, and then this kind of looks different. They really just, this means that it's originating from one cell. So we would term this monoformic. And this one is originating from multiple pacemaker cells, so we would call it polymorphic. But they're both technically VTAC. So this again will cause death if we do not treat this. The first thing that I want you to think about here is, do they have a pulse or do they not? So any of these rhythms, any of your NCLEX questions, any type of test questions, you always want to think about, do they have a pulse or do they not? So the first thing with this, VTAC, they could maintain a pulse and a blood pressure for a little bit of time. But again, if this continues, they will not, and they will go into asystole. So think about the treatment. Again, if they have a pulse, so I literally can palpate a pulse here, or is it pulseless? So if they have a pulse, that is going to be considered VT with a pulse, and you're going to think about something like amiodarone, electrolyte replacements. You're going to be doing potassium, magnesium, maybe cardioversion. So again, that cardioversion is an electrical shock. We would give that at ventricular depolarization, and we would do that for someone that's having symptoms like chest pain or they're short of breath. Now, if it's pulseless, they do not have a pulse, they are in cardiac arrest. So your first line treatment for any pulseless rhythm is going to be CPR and defib, defib, if I can say this today, relation. So again, in contrast to cardioversion, I can defib. It's that electrical shock delivered anytime during the cycle. And if they're pulseless, I want you to think about this is a code. So you're also going to be pushing epinephrine and you're going to be giving amiodarone. So VTAC's rhythm, a rhythm, but it's fast and wild, a rapid beat that's definitely not mild. The ventricles contract without much grace, a high rate over 100, taking up space. It could be life-threatening, causing the heart to stall. So shock it or treat it before it can fall. So what happens again is something, if I see something like this on the rhythm, then I'm immediately like, oh no, they are about to die or they are dead, right? So VFib, this is called VFib for the most part. It's lethal and it requires immediate treatment. So this is what we see if someone is in cardiac arrest outside of the hospital. So there is no pushing blood out of the heart here. There's no cardiac output, and that is what will result in death. So you can really see this looks like it's almost about to flatline, doesn't it? So that's, I'm always thinking about VFib and it just stops. Okay. So again, think about this could be very shaky and coarse like this, and very bad VFib. Defib. Think VFib is very, very bad. This just means this is coarse and this is fine. They're both VFib. They're both very, very bad. So what you're going to do, they are not going to have a pulse here. So you're immediately going to start VFib with chest compressions and defibrillation, and you're going to give meds. So chest compressions and defibrillation are the most important interventions that can be done for anyone in VFib. Start it immediately. You don't want to, again, you're going to follow your BLS guidelines, ACLS guidelines here. So defibrillation should really be performed within 2 to 3 minutes of onset here. But you have to start CPR right away. Now, you're going to also think like epinephrine, okay, because 1 milligram every 3 to 5 minutes, because this is a code. Now, the second medication of choice is the antiarrhythmic, like amiodarone. We again normally give 300 milligrams IV push, and then we run that a second dose of like 150 milligrams there. So when you think VFib, think defib. CPR, think death. So VFib's the chaos in the ventricle space, rapid and erratic, no pulse to trace. The heart quivers, it can't pump blood through. This is a code blue. It's critical too. No contraction, just trembling in the chest, immediate shock to give the heart rest. So what about this? Asystole. So think about there's no electrical activity originating from the heart. It's going to be a flat line. That is what is produced on the monitor. So we don't have anything going on here. There's no squeezing, there's no forcing blood anywhere here. So if I see this, like I'm out of the room and I see this come up on the monitor, the first thing I'm going to do is enter the room and make sure it's real. If you walk in the room and they're awake and they're talking to you, they are not in a systole. Do not start chest compressions. The leads are probably off. So that is going to be the first thing that you're going to do. Always make sure that it's real. So if I were to walk in the room, John, wake up, John. No pulse, CPR. Okay? Think CPR. I'm going to think epinephrine. I'm going to think what caused this. I'm going to treat it. This is a code blue. The big difference here with something like asystole versus VFib is that you cannot defib or cardiovert a flat line. So we continue to do pulse checks, we continue to do monitor checks to see if they have gone into something like VFib, because then I could defibrillate. Um, if I can see VFib, then I definitely am going to defibrillate. But if the second lead continues to show that it's a flat line, it's continued to be in asystole, then I'm just going to continue with CPR, epinephrine, and treating the cause. Simple. So asystoles, a stop, a complete heart freeze, no rhythm, no beats. It's just the heart's disease. No electrical impulse, no pulse to feel. It's a flat line on the monitor. It's no longer real. Immediate action is needed here to revive the heart, or there's danger near. I did want to go over PVCs very briefly for you. I know that I kind of mentioned that with the VTAC here. Um, And it's just that you're going to see premature ventricular contractions all of the time in wherever you're working. And they don't necessarily require any sort of treatment, but again, you have to just know the term. We have to be able to identify them. And really, when I'm looking at a strip, I can tell that it's a PVC because it just doesn't look normal. It's usually like wide, it's atypical, and it's a QRS complex that's fired earlier than expected. So there's no P waves visible before that complex because, again, that PVC originated in the ventricle. So it usually can be termed like a unifocal PVC, where it's firing again from that same pacemaker cell. And they all look the same, but sometimes on a lead, you might see them looking differently. So we could have multiple pacer cells involved, and that could be termed multifocal PVCs. Now, what you're looking for though is, are these PVCs in a row? So if we have two PVCs in a row, it's a couplet. If you have three, it's a triplet. And again, if I have 3 beats of that, it's actually a run of VTAC. So you need to notify the provider of something like that, because if I'm having multiple runs of VTAC, that's a bad thing. So definitely always be looking for those 3 PVCs in a row to be able to identify if maybe your client is something going on. Are they at risk for going into actual VTAC? So see how these look the same. wide, bizarre. Okay, like what is that? But then these other beats are totally normal. So what I would write on this, I would look at the rhythm. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You'd count it, count the heart rate. So maybe this is still normal sinus rhythm with um, PVCs. And again, what you would be able to do is, do these look the same? Yes, so these are unifocal PVCs here. Um, and sometimes they'll even term these like, depending on if they beat, how often. So a PVC that occurs every other beat is bigeminy. So if you had a normal PVC, this is technically a run of bigeminy, but then it stops. A PVC, if it was falling every third beat, is trigeminy. So that's just a very complex way to kind of term more of your PVC. See how these look different? So those are multifocal. They don't look the same. Here's your couplet. And here's your triplet. So see how that looks back to something like VTAC. And there's your couplet. There were two PVCs in a row. So my little rhyme for this one is PVCs are early. They skip the norm. A beat comes too soon, not part of the form. They're wide and bizarre. They stand out in sight. The QRS complex is not right. They might not harm, but they can be a sign of stress or heart issues in the design. So the big thing with PVCs, sometimes they can be caused by hypoxia, a heart attack, electrolyte imbalances, caffeine, high blood pressure, drugs. So the treatment of PVCs, again, is really based on the symptoms. If they are symptomatic, then you want to treat the cause. So figure out what is causing the PVCs. Now, the last thing that we're going to cover are heart blocks. And I know a lot of students really stress about heart blocks, but you really don't need to. Just think if I'm blocked, there's a delay. So in general, think there's a delay. Okay, like what is causing this delay that's going on? And I want, again, you to really think about there's different types of heart block. Now, the first one that I kind of have here is first degree. And as you can see, if you weren't measuring anything here, doesn't this just look like normal sinus rhythm? Yes, I really want you to think about that. So first degree AV block is normal sinus rhythm, except for this PR interval is greater than 0.20 seconds. So again, see, this is the P wave. Here's your QRS complex. You have to measure from the start of the P to the start of the QRS complex. That's termed the PR interval. If that's greater than 0.20 seconds, it's automatically first degree AV block. Very common. We see it all of the time. It doesn't mean that you have to do a thing for it. All we would do is document the underlying rhythm here. So maybe I'd say first sinus rhythm with first degree AV block. That might be what they write on there. Everything else is regular here. Everything else looks really good. Again, you really don't treat this. If they are having symptoms and it's just from first degree, that's super, super rare. It's when you start to get into the second degree AV blocks because there's two different types here. So we're going to go over type 1 first, which is known as a Wakey Bach or a Mobitz 1. So what really happens with this, I want you to take a peek at this picture. So what you're going to see is, we call it a little rhyme here. You can see this longer, longer, longer drop. Now you have a wanky Bach. That's how I always remembered this. So you can see that the PR interval progressively gets longer until a QRS is completely dropped, and then it starts over again, the same cycle. So this is why measuring your PR intervals is so important and why it's also important to make sure that there is a P wave before every QRS complex. So I could see there's a P wave there, there's another one here, there's another P wave here. Now there's a P wave, but is there a QRS complex? No. I'd be like, uh-oh, that's bad. That'd really be a cue that they're in some sort of heart block here. So it's not this one, Winky-Bach. I know it might seem it, but it's not considered a life-threatening dysrhythmia. It's typically intermittent or on rare, it could be continuous. So what they really do is they just look if they're having symptoms. And again, because what I'd be thinking about is a loss of cardiac output. So and if this is a slow rhythm, they're not getting enough cardiac output, then you're thinking about atropine because I'm trying to stimulate the heart to beat faster. So it's the same type of thinking as if I was in a sinus brady. If I'm very symptomatic, I'm going to give, and in this case, we normally just give 0.5 mg to stimulate it. If that doesn't work, if they're having significant symptoms, again, I'm thinking about temporary pacing. I would transcutaneously pace the rhythm. Simple. Now, on the opposite end, a Mobitz 2, which is a second degree AV block type 2. Now, this is considered a potentially life-threatening dysrhythmia because this can turn into third degree heart block. So this is actually worse than your Wenke-Bach is, than your type 1, type 2. So I know that's confusing, type 1, type 2. But if we just go back really quick, this is second degree still, right? Your Wenke-Bach, but it's type 1. And this is second degree type 2, which is a Mobitz 2. So in this case, your QRS complexes are also dropped, but in this case, every PR interval is exactly the same length with each complex. So see how here you have your PR interval. These are exactly the same. It's not a longer situation. But here I had a P wave, no QRS. P wave, no QRS. Here's a P wave, no QRS. This is just sporadic. So this is more likely to cause symptoms. So again, if the patient is symptomatic, then I'm going to do temporary pacing for this. That will be the treatment of choice. It's fast. Again, you're just going to place those defibrillator pads on the patient's chest and on the back, and I'm going to pace the heart. And again, they might definitely need a permanent pacer inserted here. Because if I go into a third degree, which is a complete heart block, now again, this is the AV node is completely blocked. I'm not getting any impulses in or out. There's no communications between the atrium and the ventricle at all. So you will see a lot of P waves without so many QRS complexes. And this is probably going to be a pretty slow rhythm. So if you see here, these arrows represent where there's a P wave, where there's no QRS complex. So 1, 2, 3, 4. Right now, the heart rate technically would be 40. But I'm still, see all this communication? There could be different amounts of P waves in between each R to R that's really just, it's irregular. So again, they're probably going to have symptoms like hypotension or shortness of breath. If there's an identifiable cause to this, you're going to treat it, but you're going to need to do transcutaneous pacing for symptomatic third degree heart block. And long-term treatment here is going to be a permanent pacemaker. So no matter what you're going to do for any of these heart blocks is think about if they're having symptoms or not. Treat the cause. If they're hypoxic, we're giving them oxygen, right? If it's a second degree symptomatic, you're going to do atropine, IV push, you're going to give pacing. You're going to call for help, right? Stay with the patient, do your frequent vital signs, prepare for transcutaneous pacing. And again, because transcutaneous pacing is uncomfortable, just be prepared to give them something for pain and something for anxiety to help with that because they are awake while you're pacing them. So third degree block is a complete disconnect. The atria and ventricles don't respect. The P waves are present, but they don't drive. The ventricles beat at their own pace to survive. It's serious and slow. The heart's out of tune. A pacemaker's needed, or they'll be in doom. There's my little rhyme for you for that. Now, if they are paced, this is a pacer spike, and I just wanted you to be familiar with what it looked like because I've had students think that this is abnormal. You actually, if they're getting paced, you want to see that pacer spike. That means that the pacer is working. So we should see one of these little pacer spikes with every single beat. And you can see this would actually be how you calculate the heart rate. 1, 2, 3, 4, 5, 6, 7, and that would be 8. Their heart rate would be 80 here. It depends on where the pacing spikes are implanted. Um, will determine like how the pacing spikes look. And I wanted to just make sure. So if it's atrial pace, then you're going to see that pacer spike before a P wave. If it's ventricular pace, you're going to see a pacer spike before the QRS. But for all internal pacers, think about that pacer wire placed in the atrium, and it's going to be under the skin near the clavicle. You'll see something kind of large out, and some of the internal pacers actually have a automatic defibrillator in them as well. So they can shock a client. Like if any of your clients go into VFib and they survive, then they will have a pacer implanted that will determine it will be able to defibrillate them. So if they do go into VFib again outside of the hospital, hopefully that will save their life. So I put the chart here to help you guys. These charts in your textbook are very helpful for treatments in chapter 29 for all of your dysrhythmias. They break it down exactly what is the dysrhythmia. If they're not having signs and symptoms, it's a totally different algorithm than versus if they are. So just keep that in mind. I definitely, all the charts in your book that go over the medications are really nice, and they have examples of all of these rhythm strips. Now, pulseless electrical activity, I did want to bring this up as well. So just because a client has something showing up on the monitor, it doesn't mean that they have a pulse. So there are rare occasions where the electrical conduction system is functional, but the heart muscle is not actually contracting. And in that case, it's called PEA or pulseless electrical activity. And if this isn't treated, that electrical conduction system will stop because there's not any oxygen going to the pacemaker cells in the heart. So what you want to do for PEA is actually chest compressions. Treat this just like because again, they're pulseless. So anytime you see that term pulseless, you're automatically thinking CPR and you're going to think epinephrine. So always make sure you're palpating for a pulse. We don't feel one, but something's on the monitor. That doesn't matter. I don't feel a pulse. I'm doing CPR. We are not defibrillating this because there's not an actual rhythm there. Okay. It's just electrical conduction, but again, we can't defibrillate that. And really quickly, we're going to go over this more in another lecture, the cardiac lecture, more fully. But because this technically does still show up as, like you have to be able to look at the leads and see what this looks like, I still wanted to go over an STEMI versus a STEMI really briefly here and much more in depth in the other lecture that I've given you guys. So when you think about an NSTEMI or a STEMI, just think about a myocardial infarction, which is a heart attack. And so think about an infarction is going to be a loss of oxygen. So this again, myocardial infarctions are the leading cause of death. So you guys, no matter where you're working, you're going to see something like this. But there's two different terms, and that is a non-ST elevation MI, which is the end STEMI, or ST elevation MI, which is STEMI. So an end STEMI is partial occlusion of, again, it could be your major coronary artery right here, that will result in partial thickness, heart muscle damage. So not as much. If you're looking at a STEMI, you're thinking a complete occlusion of one of those major coronary arteries or vessels, a major coronary vessel of whatever sort. And so you're going to have full thickness heart muscle damage. So that is going to be a little bit worse. So what you're going to see here are differences in your EKG that we get. So you have to really look at, is that ST elevated? Okay, we're always going to be doing our cardiac markers, but you're looking at, so see this P wave here, QRS complex is right here, and you have this ST depression, or you have this ST elevation. Bad. Do I want to see that? No. So just make sure that you're thinking about your EKG, and I'm thinking, is this a STEMI or not? If it is a heart attack, no matter what, you're going to do nitroglycerin, aspirin, morphine. If that pain isn't relieved by the nitro, oxygen, if their SpO2 is less than 90, and they need to go for a percutaneous coronary intervention within that hour and a half. So we always are thinking door to balloon. So my rhyme for this, end STEMI's a heart attack, but not all the way. The ST segment's normal, but pain will stay. Partial blockage leads to damage and strain. Blood flow's restricted, causing chest pain. With urgent care, the heart can be saved, but it needs attention to keep it brave. STEMI's the big one. The heart's in deep trouble. ST elevation shows massive struggle. A full blockage, no blood getting through. Heart muscle dies unless help comes through. Immediate action with PCI or thrombolytics too to save the heart and keep life in view. I did put the different types of medications that we use for a STEMI here, but again, that's just a very quick, like not even full discussion of that. I just wanted to, again, because we're talking about dysrhythmias, show you that you do need to look at the EKG. That is what the provider will be looking at there for the ST elevation in acute MIs. Write down any questions if you have them. And we will go over a lot of this in class too, but I just wanted to make something so that you have a nice reference.